So please join me in welcoming Dr. Asmaro, a distinguished neurosurgeon and neurosurgical oncologist, a proud Alpha Omega Alpha alumni of Wayne State University. Dr. Asmaro completed his residency here in Detroit before pursuing subspecialty training at Stanford, and that is where I met Dr. Asmaro. He's a fellow of the AANS and a leader in minimally invasive skull-based surgery, notably co-developing a novel liquid biopsy technique for pituitary tumors. Fluent in multiple languages, Dr. Asmaro is recognized for both his clinical innovation and his compassionate care.
Thanks so much, Jill, and thanks for everyone here and online. I love pituitary surgery, and part of it is the multidisciplinary nature. And I'm really lucky to have a lot of colleagues across the state from endocrinology, ophthalmology, ENT, neurosurgical colleagues, and I think we have. I'm biased, but I think we have great environment here in Michigan to treat acromegaly and functional pituitary tumors. My practice is actually here in Royal Oak, 10 minutes down the road in Woodward, if you don't get caught up in the dream cruise. And I'm passionate about pituitary surgery because my dad had a pituitary tumor. That's my dad and my son Luca. So he didn't have acromegaly, but he had a prolactinoma. And you've had a great talk, much better than I would ever explain about pituitary pathophysiology and normal physiology. But to summarize, the beautiful thing about the pituitary gland and why I love working on pituitary tumors and pituitary surgery is because it combines multiple disciplines from ENT, ophthalmology, endocrinology, and I wanted to be in internal medicine before I went into neurosurgery and neuro-oncology. And a lot of it revolves around the body's own homeostasis is what makes us, alive and feel well and healthy. As we have heard from previous talks, and as you already know, the pituitary glands and the brains through the pituitary gland send signals, which I tell patients it's just like pituitary glands in mailroom. It sends a bunch of letters through the blood to tell the body what to do. And these hormones, which are the messengers, they act on the rest of the body. And things can go wrong. At one of the most common primary neoplasms of the CNS is a pituitary adenoma, pituitary tumor. Luckily and thankfully, fortunately, it's benign. But it can exert massive effect. It can put pressure on adjacent structures. And when it's large enough, it can compress the optic chiasm, as we see over here. And this is a large heterogeneous, meaning multiple signal intensities. T1 bribe also enhancing pituitary adenoma. This has some hemorrhage in it, so maybe this is what patient presented with apoplexy. And I tell patients neurosurgery is time and pressure. My favorite movie is Shawshank Redemption, right? Time and pressure. So you have a large tumor growing slowly. Patients don't even know they have a visual field deficit. But they can have a little small tumor, and if it hemorrhages acutely over seconds, minutes, they will present blind with double vision. So not all tumors are the same, and that's why every patient is unique, so there's individualized treatment. And patients often present with bitemporal heminopsia because of compression of the optic apparatus, and they will have this tunnel vision when they come in. And hopefully they come in before this happens, but a lot of times they come in when this is far advanced, and some of it, unfortunately, is not reversible. And aside from the optic nerve compression, some of these tumors act like their own uncontrolled gland, and they continue releasing hormones. So growth hormone will cause acromegaly, ACTH excretion will cause Cushing disease, TSH, very rare, hyperthyroidism, and prolactinoma is another one that's not here. And if for growth hormone, as you know, you will continue acting on the body, changing a lot of the physiology, causing a lot of pathologic states, but also changing morphology, which is very unique to acromegaly. And to some extent, Cushing does something similar by causing metabolic syndrome. The treatment for this was started by the father of modern neurosurgery over 100 years ago, Harvey Cushing. Harvey Cushing was kind of a renowned neurosurgeon, and he started documenting his work really, really well. And that's how we started understanding how to treat a lot of brain tumors through his work. This is a unique case. He was attempting a lot of these sublabial approaches with this torch. His residents, with their hand would burn because of the light. And then he was also trying these Schlaffer incisions, the modified omega, through the forehead. And as you can see, they were administering ether through the mouth. So he would plug up the nasopharynx with a sponge here. And then he developed endotracheal anesthesia. So the modern anesthesia also started with neurosurgery. So something to brag about. And then Jules Hardy in the late 60s came in and introduced the operative microscope for surgery. And that's where really it took off, microscopic TSH, transsphenoidal hypophysectomy. And I kind of very dislike that term because we don't do hypophysectomies. We do not remove the pituitary gland. At least we should not, right? So, through the centuries, this is what it looks like. The Egyptians were removing the brain of the mummies through the nose, then Harvey Cushing, then Jules Hardy, and they were using intra-op X-ray to see where they are in the sphenoid sinus. And they didn't have MRIs back then, so they would leave a clip on the sella, metal clip, and they would take X-rays. And if the metal clips moves, that means the tumor grew back and it pushed the clip away. And then, the operative microscope and then endoscopy came about mostly in the last, 20, 25 years. And if we look why there's a shift from microscopy to endoscopy for pituitary surgery, the shift is, it's clear why. This is where you put a speculum in the nostril, in one nostril, and after you open up the sphenoid, you see the sella and the clivus, and you put a microscope from outside. And if you open up the sinuses, and we usually do this with ENT nowadays, at least in a lot of large volume centers, we have specialized skull-based ENT rhinologists who will do a wonderful job opening up to this view in the sphenoid sinus. You see a lot more than just the sella. And instead of just here, you get a wide view of the optic nerve, carotid, and this is going to be the cavernous sinus over here on the left, on the right. So the view is much better. This is a vacation my wife and I took in Italy, in Lake Como, and this is a nostril and this is a microscope. This is what it'll look like, zooming in on it. But if you put an endoscope through the door, you get a much better view. So the shift is clear. Over the last 2 decades, and this paper was published with older data, as it takes a while to trickle in, but from 2003 to 2013, it went from 1 or 2 centers doing endoscopic pituitary surgery to 50%. And if we extrapolate it to now, another 10 years, it's probably 80% doing endoscopy instead of microscope for pituitary surgery, acromegaly surgery. So there's a clear trend toward endoscopic endonasal approaches. And you can almost say it's standard of care, right? If you go to any center that's doing 2, 3, 4 pituitaries a week, they're doing endoscopy. But if we look at the results for endoscopic versus microscopic surgical treatment of acromegaly, no significant difference in biochemical remission rates. So patients are getting the same outcomes. You get much better views, nicer views. The surgeries are taking a little longer maybe because you're working with, now it's 2 teams, ENT, you open up the sinuses more, but 45 to 35%, but this is not statistically significant. So meaning it's a wash. Changing from microscope to endoscope made no difference. And this is a big multi-center study looking at gross total resection rates of large tumors, pituitary tumors, not just acromegaly, and also found no difference between surgeons who are still using old microsurgical techniques versus endosurgical techniques. So how do we improve outcomes? We're getting nicer views with the shift in visualization, and is cavernous sinus surgery still contraindicated? This is a systematic review and meta-analysis of acromegaly treatment, so combining many research projects and many studies. Overall, if you combine multiple studies from all centers across the world, it comes to about 55%. So 55%. So you go to surgery, first-line treatment, half of you would get remission and the other half would have to find further treatment. So can we do better, right? So it does, and this is the talk we need to, that's why I love the acromegaly community, because it bridges all these multidisciplinary doctors and community leaders, and we're not working in silos, right? Because you have to make the best decision for you, and you can only do that if you're well informed about what happens on the other side, right? So it's equivalent of saying, I'm gonna grab dinner today, but the dinner can be anywhere from a 5-star Michelin star restaurant, or it can be, sushi from the gas station that's been sitting for 5 days, right? So yeah, it's food, but is it the same quality, right? This is a 30-year-old young patient who kept presented with bitemporal hemianopsia. He has a very large cystic suprasellar tumor. This is the pituitary gland. You see this thin rim over here that's a little brighter than the rest of this. This is the pituitary gland, how compressed it is. And that's why these patients with large tumors have hypopituitarism, meaning the gland doesn't function, just like Dr. Corey said, that thermostat is just not working too well because of the compression. So cystic lesion, nodular component, this is after his surgery. So he goes for surgery and this is post-op. It doesn't take much, you don't need me to say it, but that's not a good resection, right? So unfortunately, he makes his way to our clinic a year after. So this bitemporal hemianopsia at that time was permanent, right? He already had thinning of his optic nerve, but at this time we finally gave him a resection, took it out. That's a pituitary stalk. Optic chiasm is finally in view now, and that's his tumor. A pituitary gland, no tumor. So it makes a difference where you go. And this is another story of a 51-year-old progressive bitemporal hemianopsia. The surgeons went in. It was pretty fibrous. It was tough. So they were relying on traditional techniques, post-op MRI. So this is pre-op. This is the sagittal view. This is the pituitary gland. You see that thin rim of enhancement on the right side. The pituitary tumors are not very vascular in particular. So on the contrast MRI, they don't show up as bright as a gland. The gland has a lot of blood to it. So this is the gland here, that thin rim that's 1-2 millimeters, mostly on the right side. This is a carotid artery, and this tumor is, pushing on the left carotid artery a little bit, and pretty large extension. So this is post-op. Also, this another patient who didn't have a good, meaningful recovery. So what is the advancement in pituitary surgery? How can we do better than those 2 patients we just saw? And if we're looking at a lot of centers, they're doing endoscopic surgery, which have progressed from microscopic, like the data suggests. But that's in the world of surgeons who are pushing the boundaries, that's still considered late majority. People are expanding a little bit, going a little bit above to the optic nerve, peeling tumor off the optic nerve and whatnot, and that would be considered early majority. And I think that the reason I went with Dr. JFM is because the early innovation is happening where tumors are being removed from the cavernous sinus, where it was considered a no-op zone, non-operative zone. And the reason is because of the delicate structures, difficult to access. It really needed a very, very deep understanding of the structures within the cavernous sinus. And it came from a very disciplined sequential studies that described this anatomy and how to approach it safely. This is the pituitary gland. This is the cavernous sinus that traditionally we didn't even see. But then we learned about how to open it up, how to access it safely, how to disconnect these ligaments, how to protect the carotid artery and remove tumor from this previously non-operative zone. And the reason it makes the most difference is, the place where it makes the most difference is acromegaly, more than any other type of pituitary tumor, and I'll show you why through some research I did in fellowship. So this is the cavernous sinus medial wall. So pituitary tumors would push on the gland here, but they can also invade this space. And if we're relying on traditional techniques, we are leaving all that tumor behind. This is a traditional view from a microscope or endoscope. So that's why those results are no different between the two. You have to have an expanded endoscopic skull-base approach to get this view of the cavernous sinus and whatnot. So you can get this view, you can have the right team and tools, great, but you have to learn how to get into it, which is the next challenging step. And the reason is, it's because a lot of tumors in this study, one of the early studies that came out, it showed that medial wall of the cavernous sinus shows invasion by pituitary adenomas, pituitary tumors, up to 86%, right? So some tumors, again, this is a biased study because they were only removing cavernous sinus walls that looked invaded, right? So the data is skewed. So, but it gave us a good glimpse that there's a lot of invasion happening that before, using traditional techniques, we just ignored. And this paper was published about 5 years ago, right? So not a long time ago. So what does it mean when surgeons started taking out the cavernous sinus wall? A lot of studies by Mentor, for prolactinomas, the remission rates were going up. So from traditional 70%, as the center was doing, traditional techniques to 90% for smaller tumors, and from 43 to 70% for NOSP3 tumors. So they were learning, getting better results. So there was definitely something there, right? And how do we classify cavernous sinus invasion? A lot of you go to the surgeon and they'll tell you the MRI shows NOSP classification. You heard it, the Hardy NOSP classification on previous talks. And it's basically looking at the MRI and looking at the relationship of the carotid artery in terms of where this tumor is. And if you draw a line medial to the cavernous carotid artery between the tumor adenoma, you'll say that if it touches that line, it's a 1. If it touches the half line, it's a 2. If it touches the outside, it's a 3. And then if it goes around the carotid artery, it's a 4. And then neurosurgeons, we've been taught that if it's a 0, 1, or 2, there is no cavernous sinus invasion. That's just pressure. And that's something that just didn't make sense because we were taking out tumors with NOSP 0, 1, and 2, and we were not getting patients of acromegaly in remission, right? So something didn't make sense. And that's kind of what I was really interested in fellowship. Take for example, this patient, 18-year-old, history of macroadenoma, co-secreting growth hormone and prolactin. So it's a somatolactotroph, been on cabergoline for 15 years. Prolactin is normal because on dopamine agonist. Tumor shrunk, but the IGF-1 was elevated for 15 years. So he also was lost to polyp a little bit, and he had compression of his optic nerve. So this is before treatment. It shrunk on cabergoline pretty good, right? Looks nice, but the IGF-1 is still elevated. And I think he got an opinion and there was no target to operate in the pituitary based on MRI. Well, if you look closely, this is his stalk. This is his optic chiasm. This is clear gland, and you look, it looks a little bit dark here. And looking back in hindsight, that's why I tell all patients, please bring me all the images, especially before any treatment. It was intimate with the right cavernous sinus before when he was first diagnosed. This is the carotid artery. The really bright stuff is the venous blood of the cavernous sinus. Again, adenoma is a little darker because they're not vascular tumors, which makes them easier to take out. But we know it's touching the wall of the cavernous sinus, but cavernous sinus looks clean. So I was suspicious that this is the tumor here. So talked to him and told him, we'll go in, clean it out. And he's like, he agreed. So here we are. This is in the sphenoid, opening up the sella. And this is the cavernous sinus on the right side, exposed, the carotid arteries behind that membrane. This is the dura we're dissecting. This is pituitary gland. And here we are, we're seeing that tumor. Sure enough, on the MRI, it wasn't very visible. And because there was a big tumor and it shrunk on cabergoline, this is actually the pituitary diaphragm that has kind of collapsed down as the tumor shrunk. Now, this is the gland over here. This is the diaphragm that's collapsed kind of as the tumor shrunk on cabergoline. And this is now pituitary gland here on the left side of the patient. But we know there's tumor left, and I was very suspicious there's more tumor in the medial wall of the cavernous sinus. So now I'm opening into the cavernous sinus over the carotid using the specialized tool, and this white thing is the carotid artery. Some venous blood that's expected and normal. Looks a lot on the endoscope, but it's not much blood. And this is the medial wall. We're peeling off the carotid artery, cutting these ligaments very carefully. These procedures take many hours, so it's not one of those that we would book many cases. It would sometimes be the only case of the day, so we can really take our time and take everything out. So, because taking every last bit really matters. So now this is into the cavernous sinus and removing the last bits of tumor of the cavernous sinus medial wall, disconnecting the ligaments. And here I am just cleaning the rest of it out. And here is at the top, next to the diaphragm, there's more tumor that was kind of hidden. Basically, the dopamine agonist kind of made it a little difficult, but we were able to clean it out and get this guy in remission, which is nice. So what is this? According to that MRI you saw, on his first diagnosis, that was a NOSP1 tumor, right? So a lot of surgeons and how we were all taught in training and literature that if it's NOSP 0, 1, and 2, there is no cavernous sinus invasion. So we took our data and looked at them. And sure enough, grade 0 tumors like this one, which you see the tumor here and the gland here, pushing on the left, it's not touching the medial wall between the carotids. It's a grade 0. We found 10% invasion. If we have grade 2, where we draw a line between the two carotids, it's about almost 45% invasion, right? So MRI doesn't tell the full story. There is microscopic invasion, and that's a reason we are not getting good remissions using traditional techniques. Basically, if we look at it from a sensitivity specificity standpoint, is how we look at every diagnostic studies. It's like if you were to get your blood checked, there's going to be false positives, there's going to be false negatives, right? A test will have very small number of false negatives and false positives to make it a really good diagnostic test. But MRI, if we rely on MRI alone, we're going to fail to identify 60% of cavernous sinus disease. So what is the difference? Why is acromegaly different? And this is some of the work I did in fellowship and continued down after coming back to Michigan. If we look at the Rathke's pouch stem cell where pituitary adenomas form, or pituitary cell line forms, it's 3 cell lines, T-pit, that makes corticotroph lineage, PIT1, these are like embryologically, as the embryo is developing, starts from one stem cell in the pituitary gland and forms these cells, and SF1. So the PIT1 is the one that forms acromegaly or prolactinomas. So prolactinomas and acromegaly are same sisters, tumors. And the reason it makes a difference is PIT1 has 50% cavernous sinus invasion even when the MRI is negative. So that's why historically remission rates for acromegaly have been 50%, is because the other 50% have been in the cavernous sinus. And this is kind of the work, when we put this together, it was kind of a whoa moment. Like, we expected to see some data, but this is like, whoa, it fits historically, which is fun. We don't always see that when we do research. So, and we, for co-secreting tumor, like that gentleman we had, same thing. So acromegaly, co-secreting or prolactinoma, the PIT1 family is just those cells are just very caverno-invasive. They invade the cavernous sinus. And we did put it through an AI machine learning algorithm and confirmed the diagnosis or confirmed the findings. This is a paper that we worked together with my good friend, and we looked at corticotrophs, for example, and somatotrophs. So this is a Cushing patient, this is an acromegaly patient, and 2 similar looking tumors. This one has invasion of the cavernous sinus wall after we take out the rest of the tumor. This is the gland, normal gland, and we can confirm it with histopathology. So historically, like I said, 50% remission rates, but if we take down the medial wall of the cavernous sinus, the results were up to 92% remission rates. And this is another patient who had a previous transfemoral surgery, microscopic, young lady, 30-year-old, did really well, but her IGF-1 was still elevated, 455 above the reference. And she also had recurrence, so she was referred down from up north. And we were able to disconnect that medial wall. Now on the left side, disconnecting it from that carotid artery. And you can see that the medial wall is not that thin membrane. It has tumor in it. Now, this is the carotid artery looking clean, and we're stimulating cranial nerve 6 and 3, and we're able to remove the rest of the tumor and preserving her normal pituitary gland. She's 30, and it's very important to have your pituitary. So this is post-op, and you can see the gland stalk, and then she's in remission without medication. So if we look at the results for transcavernous surgery, remission rates, that's what I quote patients, 88% for acromegaly, and microadenoma gross oral resection is 100, for larger tumors 91, and patients do really well with these results. And so what are some things you should know about what makes a difference? I think like a lot of things, we fall for our brand names, but you really want to go to specialized areas where you have people that have dedicated skill sets, expertise, and experience. And this is at MRI. MRI makes a difference. You have to have not just three Tesla MRI that can show you the better imaging, but you need to have the right protocols. So when I came back from California, one of the first thing I did, all the MRIs I would order on, we just reconverted all to thin cuts, pituitary skull-based protocols. So we have the field of view is different, the cuts are different, the timing is different. So we have a lot of it's not every MRI is the same, not just even 3 Teslas the same. So that's why I'm very particular about where patients get my MRIs, especially microadenoma because I want to see it, but also macroadenoma because I want to see cavernous sinus work invasion. This is what a nice MRI would look like under that protocol we have. And so you can see even the cranial nerves within the cavernous sinus. This is the left side cranial nerve. We can see this is shifted a little bit, but this is going to be cranial nerve 3, 6, V2. So, and this is the tumor here, and that's a gland. So where you get your MRI makes sense. This is a patient was referred from Michigan, 45-year-old, elevated acromegaly. This is originally had surgery on that left little piece of tumor, was still elevated IGF-1 despite octreotide. And then he went to his local neurosurgeon and they said, well, this is your local MRI. There is nothing. In the read, there was no adenoma, MRI read, right? So we brought him in, we did that specialized protocol, and sure enough, you can see something now on the higher resolution. So this is both 3 Tesla, but it's a protocol that matters. The reason a lot of places will not do this is because it's double the scan time. So they will say, we can scan less patients, it pays the same, right? So, you need someone who's gonna be your advocate, who's gonna really make sure they know where to get the MRI, because not every MRI is the same. And these can be large academic centers or whatnot, it doesn't matter, right? They have scan time, they want to get patients in and out, they have a backlog, patients are waiting 3 months. But this is what's non-negotiable to me, it's important. So yeah, maybe it'll take an extra 10, 15 minutes on the scanner, but that makes a difference to me as a surgeon to plan surgery, but also for the patient, right? So this is very important. It's actually, all the places, they still don't have them as standard. They have to, a lot of places will have to say, sell a Asmaro protocol so the techs will know to pull up that special protocol because it's this, they don't want to overuse it. But I think it's important for patients. So anyway, so we see a little on the special protocol, we see the MRI. So this is, and then we go in, a lot of scar from the previous surgery. We separate it and open up the dura, which is this, and scar. It's not as like a first-time surgery you can see. But sure enough, you can see adenoma here, kind of that tumor, a little fibrous because it's been pre-treated with octreotide. So sometimes it makes the tumor a little more fibrous, not as soft. This is dorsum clinoid, posterior clinoid. Now we're opening that membrane of the cavernous sinus over the carotid. Normal venous bleeding expected, and we have all the tools to stop it. It looks like a lot, but this is just like 20 cc's of blood, and it stops with the right material and medications. And now we're separating that tumor off that carotid artery, and you can see the medial wall now is so beefy, full of tumor. The on MRI looked negative, right? Even the specialized protocol was like, there's something there, but in real life, it looks a lot more, and that's why the IGF-1 is not normal. Either at the end, we take it out, this is the reconstruction from the ENT team, looks nice. and we can get this patient off octreotide. I think he was paying a few $100s a month, and he was ecstatic that he doesn't have to pay anything, and now he's on remission and doesn't have to worry about any injections. And he still invites me every year up north for whitetail hunting. The first time he mentioned, I was like, yeah, for sure. Turned around, looked up what that is. I was like, oh, deer, okay. So I guess I need some more hobbies outside the OR. But actually, my team invited him to the conference, and he's like, we'll tell Dr. Asmaro I'm still waiting for him to go hunting. So good guy. This is another patient, had left eye blindness, acromegaly. This is the gland. You see the thin rim here is the gland. Over here looks 3A, NOSP 3A. Large tumor. She was blind when she came in. She had a really good resection, but she has this nugget left behind. And she was on lanreotide, residual disease. Her IGF-1 was elevated. So we elected to take her back now with this cavernous sinus surgery. And we can see there is a lot of scar tissue, but it just, we take our time. This is multiple, a lot longer than the initial surgery for sure, but as long as it takes to do safely. This is the carotid artery, and we separate this medial wall of the cavernous sinus, and we can see it's very invaded with tumor, just like the MRI suggests. This is not even, it's not even questionable here. So this is whole medial wall over here is full of tumor, and this is carotid, cavernous sinus, full of tumor. We're separating it ligament by ligament, small vessel by small vessel, until we get all the tumor out. And now this is looking through an angled endoscope. Carotid inside the cavernous sinus is full of clean of tumor, and we can stimulate the cranial nerves and get her in remission. This is a piece of fat graft for reconstruction, and she's off medication. And we can even tackle large tumors. This is a 45-year-old lady with new onset seizure, and Dr. Corey, I think, once called me and saw her, and she's like, something is off, IGF-1. Before it came up, she was diagnosed here clinically, and her IGF-1 sure enough came back in the 600s. This is a large tumor. This is pretty impressive. This is the gland, what's left of it on the right side, hemorrhage, because of hemorrhage, and that's why she had, but this all around the carotid artery. And it goes all the way towards the temporal lobe. This is the hippocampus that is responsible for memory, and this is the left side, so dominant for most people who are right-handed. So that's why she had a seizure. It's very uncommon for pituitary tumors to cause seizures. And then I did this as a 2-stage operation, endonasal first, took out all this tumor. It has not been pre-treated. This is very soft, and this is a Doppler listening to that carotid artery, and we're disconnecting those ligaments. Drilling that skull base, pretty large tumor going all the way through the clivus, all the way up. That's a normal gland we're protecting. Now that's normal dura, it's cleaning out. And now I'm stimulating for cranial nerve 6 and removing tumor off of it. So lots of structures. Now working toward the left of the carotid, cranial nerve 6 here. And then we took out all this tumor. This is the gland that we saw before, tumor here. That's what's left behind. Kind of, I reached the limits of a safe endoscopic endonasal approach. While all this tumor that you saw before is out, so I took her back the week after. Now this is a craniotomy with a microscope, not through the nose. Took out this thinned out clinoid process around the carotid. Look at the tumor all hidden there. This is going to be near the optic nerve. Now this is the temporal lobe, and I'm removing that tumor that was invading the temporal lobe. I just wanted to give her the best chance of remission. She's a young lady, young woman, and that's tumor now next to the third nerve that makes the eyeball go in all the directions. And now I'm accessing the cavernous sinus from above, which is this area of the cavernous sinus is much safer to access via craniotomy, which is very safe. She still went home post-op day 2 or 3. And this is post-op. Now that tumor you see here is gone. So the carotid artery, which you saw tumor all around, now it's clean. This is all post-operative changes. And her IGF-1 is normal. Last time I saw her, which is about 3 months plus post-op. So for repeat surgery, for patients who've had surgery and they want to come in because they hear about this cavernous sinus, transcavernous approach, there's a few centers in the US that do it. Do your homework. Patients always ask, how do I know? if your surgeon has trained at two places, UPMC or Stanford, within the last 5 years, they will do this approach. That's the bottom line. Otherwise, maybe there's some people who are self-taught from going to courses or coming to our talks. So the outcomes is about 70% surgical remission for acromegaly redo. It's not as robust as 88%. Some of it is scarring, because once you have surgery, it can cause some scarring. So sometimes we're hesitant to be too aggressive, especially because of the vessels or whatnot. What about radiation for acromegaly? I get this a lot. It's a delayed result, but also a delayed complication. So radiation, unlike surgery, average is 3 years to remission. Remission at 5 years is about 40%, 43%. 10 years is 60% from published large multi-center data. 1 in 4 patients will lose their pituitary function after radiation, so you'll end up on hormone replacement, much higher, a lot higher than surgery. And 4% have vision loss or double vision. So it's an option for patients who are not good surgical candidates. I don't think radiation is a great option for patients otherwise. But for sometimes small tumors, it can be. I would suggest if you're going to do the radiosurgery route, have a neurosurgeon part of your plan. Because a lot of times, if they don't have the right MRI protocol, and I have seen this firsthand, they will target some small cyst within the gland, and the whole tumor in the cavernous sinus is not part of the radiation plan, right? It can be hidden. So if you don't have the right protocol to kind of tease it out, it can be hidden. So, and believe it or not, it happens often. Not every time, but it happens often, right? So you want a neurosurgeon who does a lot of pituitary surgery to be able to tell the radiation oncologist, include that part in the plan or not. I've done hundreds of pituitary surgeries. I've done only one case of SRS for acromegaly, and I was there for the plan with the radiation oncology and during the treatment because I wanted to target. It was one of my post-ops. She had a surgery a few years before I was practicing. I took her back for a transcavernous, but she had a lot of scarring. She's one of those 23%, 30% that don't have remission. I shrunk the tumor. I had left a little microscopic disease. We did SRS. That was part of the planning, and then she's in remission now. So there's ways to do it safely. Also, what I do if I'm surgery, I cannot take out the full tumor because it's a redo. What I do is I take a piece of fat from the belly, put it between the gland and the tumor, separate it. So when we go for SRS, there is a lot of space. The radiation doesn't affect the pituitary gland. So there's a lot of things we can do that we can think about. And then, there's a lot of cool stuff happening from Dr. Castro's lab about pituitary liquid biopsy work. And hopefully this is the future, but it's going to take a few decades to get there. We're all here because of the mentors, and my mentor is from residency. It's Dr. Rock, who's here, who got me interested in skull base and taught me skull base surgery. And then Dr. JFM from Stanford. So they're both really good friends and mentors who I lean on all the time. And I just want to, thank you guys so much for the opportunity. And I want to thank the acromegaly community and Jill Sisko. I think I treat a lot of pituitary tumors, non-functional, functional, but the most robust community is acromegaly community. And I think we're really all fortunate to have each other. So thank you so much for your support.